Ladies and gentlemen, welcome back to our medical talk show. Today, we have a special guest joining us from South Africa, a distinguished clinical oncologist from the KwaZulu Natal Department of Health, Dr. Presha Bipath. She has made a significant contribution to the field of oncology, specializing in radiation oncology. Additionally, she holds a master's degree in clinical medicine in oncology from the University of KwaZulu Natal. Not only she is a practicing clinical oncologist, but she also serves as an honorary lecturer at the University of KwaZulu Natal, where she shares her knowledge shaping the future of oncology care. Today, we have the privilege of discussing a critical topic with her, brain metastasis in oncology, its detection, diagnosis, and treatment. Welcome, Dr. Presha.
Thank you, Dr. Nijar. It's a pleasure to be here, and thank you for that lovely introduction.
Thank you so much. Let's dive right into our discussion. Dr. Presha, what led you to choose a career in oncology, and do you have any advice for aspiring oncologists?
Okay, so Nijar, I must be honest, with our undergrad degree and our exposure to oncology is actually very limited. So it was not at that point where I thought, okay, oncology is for me, contrary to other disciplines where you have a lot of exposure. It was actually during our internship post-medical school where we went into the field and we were the ones who were actually detecting these cancers. And for us, the specialists or the oncologists were very high-ended and were a bit hard to get a hold of. And we always thought, oh, wow, they sit up in their offices and when the patients come back, they're cancer-free. And wow, these oncologists actually perform miracles because we don't have much insight as to what they actually do. So then I decided, no, this is something that I need to inquire about. So after we had done our internship, I made contact with the head of department in oncology, and he said, come in and have a look at what we do. And when I actually went and had a look at what they do, I was actually amazed. And it's at that point in my career that I thought, no, this is something that I want to be a part of. This is something that I want to pursue. It wasn't easy. A lot of the times, even when I applied for the interviews, a lot of the times they had told me no, but it just took persistence because there were a lot of applicants, and oncology is quite popular in our country. And then eventually, eventually I got in, and to this day, it is something that I have never regretted. So my advice to anybody wanting to pursue oncology is just persevere. If it's something that you're really passionate about, we know that there will always be obstacles in whichever turn you take. It is something that, we are light years from this ever going away, from cancer ever going away. So there will always be a need for you to pursue oncology. It is not a mistake. It is never something that you will regret doing. Whenever you treat a patient, you just need that one patient to tell you that they're cancer free. Yes, it has its negatives, and we all know, but it's just that one patient that makes everything worth it.
Wow. Thank you so much for your story and for your excellent advice for the aspiring students, Dr. Presha. Now, let's talk about brain metastasis. Which primary cancer types are most commonly associated with brain metastasis, and what factors contribute to the spread of cancer to the brain?
Okay, so in order of incidence, the most common cancers that metastasize to the brain include breast, lung, melanoma, and prostate. Those are the 4 common cancers that actually metastasize to the brain. When it comes to contributing factors to these cancer itself, they're multifactorial. And, cancer is something that's very heterogeneous, even in a certain subsite or disease entity. So, for example, with breast cancer, it's not the good prognostic breast cancers. It's the negative prognostic breast cancers, like your triple negative breast cancers. For your lung cancers, it's your small cell lung cancers. So it's the specific subtypes of those cancers that contribute to an increased development of brain metastases. But even in that spectrum of disease, like you wouldn't get an early stage triple negative breast cancer very easily metastasizing to the brain. It's also dependent on stage of the cancer. It's also dependent on how far it has spread to other organs in the body. And the main factor is compliance to treatment. If you ever want to be successful in your endeavors, you need to have a compliant patient. So if somebody is going to default their treatment, then yes, those cancers are going to spread and progress. So those are the main contributing factors, or predisposing factors, that can actually contribute to the development of brain metastases.
Thank you, doctor, for explaining. It is evident that early detection and intervention plays an important role in patient outcomes. Moving to the next question, how important is early detection and intervention in brain metastasis, and what are some of the subtle signs and symptoms that doctors should be aware of, and how important is this early intervention?
Okay, so early intervention is paramount to achieving curative treatment. And yes, a lot of doctors may think, okay, but the cancer has spread to the brain, it's not at a point of cure. And this is not true. Now with advanced techniques, now with better surgical skill, there is a chance of curing a patient. Obviously, it has to be a select patient whose primary is controlled. So early detection definitely leads to curative treatment, right? So that's one of the reasons why early detection is so important. It's important for this to occur that everybody understands the signs and symptoms of this disease. So I'm very happy that you've actually asked that question, Dr. Nijar, about how do we detect these subtle signs. And the signs can be varied, right? Because obviously, like we said, cancer is heterogeneous, and no patient is like a textbook, right? So, but the usual worrying signs for a cancer deposits in the brain is that that they've got a primary cancer. So, they have a history of either breast or lung cancer, or even at first presentation to you, they have a breast mass, or they have fluid in their lungs with actual lesions in their lungs. That gives you a suspicion that, okay, there's something worrying here. The signs that are specific for cancer metastasizing to the brain is headaches. And these headaches are more so in the morning. That's a cardinal feature of this is something that we need to worry about. Those headaches are associated with vomiting because obviously they're related to raised intracranial pressure. So this pattern of headaches will be very different from somebody who has hypertension, where the headaches are chronic and they're long drawn out and they wouldn't be associated with vomiting necessarily. So these are cardinal signs that will alarm us or alert us to think that we need to actually investigate these patients. On the flip side of the coin, yes, you can get the odd presentation where, the other thing that they may present with is seizures. They may start fitting, they may have actual neurological signs where they may have a hemiplegia or a paraplegia. And this is often something that develops quite rapidly. So over a short duration of period, with a period of weeks or months, especially without intervention, a cancer can actually progress quite rapidly. So that's one of the cardinal features, opposed to it being not another or a benign entity. Like I said, you can get sequelae of other presentations, and this I've had a patient who initially presented with just blackouts, and this actually came back as absence seizures. And it was, ordinarily we wouldn't have actually scanned the brain, but it's only when we did scan the brain that we picked up that it is actually a deposit in the brain. You can get those patients who can even present with personality disorders. It actually depends on where the lesion is. So yes, we do have the routine presentation, but don't forget that they can present in a weird way like cancer does. So there's no reason why you shouldn't contact the oncologist if the patient has a known malignancy to actually say, is this something that I need to be worried about?
Exactly. Yeah. Thank you so much, Dr. Presha, for highlighting this critical role of early detection and improving patient outcomes when it comes to brain metastasis. Also, it is important for the doctors to maintain this high index of suspicion, particularly in patients with history of cancer, as also when it comes to these neurological symptoms, they could be misleading but at the same time could potentially indicate the presence of brain metastasis. Let's move forward. Treating patients with brain metastasis presents unique challenges. Could you elaborate on some of these challenges in treating patients with brain metastasis?
Okay, so initially when a patient develops brain metastases, it's not something that they are aware of. So that's the first challenge. We rely on the caregiver to identify that the yes, they can often say that I have headaches, and they are patients who are worried about it because of the rapid progression. You rely on the caregiver to say, no, this patient is now weak or is vomiting and not themselves. The other challenge is that the patient can present with an altered level of GCS, which means that they are not aware of what the current diagnosis is and what what diagnostic investigations we need to do and what treatment we need to institute, which means that obtaining consent is a logistical issue. For our treatment, we obviously need, for example, for radiation, we need the patient to understand what it entails and to lie still, for example. Now, if a patient doesn't understand the reasons why we need to do this treatment, and we obviously put a patient in a mask, which is an immobilization device, they often give us challenges in that because they don't understand. They feel claustrophobic. They feel that we're doing harm to them. They cannot lie still for that period of time. So it makes it very difficult. And obviously, there are ways around it, like sedating. And it's not something that we can obviously do or would like to do openly because of the fact that the patient has neurological deficits. So their function is not ideal or optimal. The psychological challenge of it is to actually explain, and this is throughout with most logical diseases, especially when it's in advanced stage. Yes, if cancer has spread to the brain, it is stage 4. Yes, there are patients that we can cure, but it's those select patients that we cannot cure and those patients that are too far gone. So as much as we've been trained in breaking bad news, nothing actually prepares you for the patient's response and how they actually understand. Sometimes they don't understand. So it's not an ordinary breaking bad news. We're telling the patient you've got stage 4 disease. You have limitations in that they don't understand what's going on, but you still have to tell them this is the issue. Have to tell them that this is, the caregiver, that this is the issue. So that's some of the challenges that we actually experience when it comes to treating and diagnosing and managing these patients.
Thank you, Dr. Presha, for emphasizing on the complexities involved in patients treating with brain metastasis. It must be very challenging to break the bad news to the patients. Yeah. Now, let's shift our focus on distinguishing between primary brain tumors and brain metastasis, as it can be a challenging task. Could you please shed some light on how clinicians differentiate between the clinical presentation and evaluation to make an accurate diagnosis?
Okay, so initially when a patient presents with a brain primary brain cancer, like we said, the patient would present with an actual primary disease. So they will have a breast lesion, they'll have a history of a primary lesion, they'll have a lung deposit, or they'll have an actual skin lesion, which says that, okay, this could be a melanoma. So that's one of the important features that can be assessed clinically from the doctor itself. The second thing is that, like we said, the presentation with the headaches that are associated with vomiting, that are rapidly progressive, that can present with seizures, as opposed to a primary deposit of the brain. Yes, as much as you get those aggressive primary brain tumors, but those that are non-aggressive, they usually have a long drawn-out presentation, which means that those headaches are of a chronic nature. They're of a long duration, for example, more than 3 weeks in terms of their presentation. They're not often associated with vomiting. They're not often associated with seizures. Yes, you can present with seizures as its own sign, but a collection of symptoms would lead the clinician to believe that this is something that has deposited in the brain as opposed to a primary deposit. Then there's obviously things that you can do which are non-invasive, which is like blood. Now, most cancers like that metastasize to the brain have markers, like tumor markers that you can do, which is simple to do, and it's usually a blood investigation. For a breast cancer, you can do a CA15-3, which obviously, if elevated, means that this cancer there's active cancer cells that are progressing. For a lung cancer or for a prostate cancer, you can do a PSA. For a melanoma, you can do an LDH. So those are things that are, you can usually do without having to scan the patient to get an idea. And then obviously the main investigation is a scan.
And on the scan itself, a CT brain, that's the first gold standard that we do to investigate these patients. You can see on the scan itself whether it's a primary deposit or whether it's a secondary deposit. And a primary deposit will usually have what we call a rim enhancing lesion. So it's usually something that has a border, and it has a necrotic center, which means the tissue inside is dead. As opposed to a primary brain cancer, which, when cancer spreads, it spreads in an organized fashion. So if it starts off in the brain, it will be very infiltrative in nature, not organized or not well fashioned, as opposed to a secondary deposit, which will have a border and, depending on how extensive it is.
Does it mean it will look more symmetrical?
So it will have an actual rim enhancing lesion. It will be a lesion that will have an actual rim around it and a center which has dead tissue, as opposed to an astrocytoma, which is a primary brain lesion, or a glioblastoma, which will be known to be infiltrative, which means it will grow in a nature that will invade the surrounding structures without rim enhancement. Yes, you can get rim enhancing lesions in a meningioma, and obviously those are also primary brain tumors. But like we said, you need to take things into context of, the presentation and the imaging features. And if you can't further define it on a CT scan, then you can obviously do an MRI. And based on the specific weighting, whether there's T1 weighted images or T2 weighted images, that can further define the lesion and see if there's if it's actually a primary deposit or whether it's a deposit from a secondary brain cancer or breast cancer or lung cancer, etc.
Thank you, doctor. This really explains the importance of comprehensive evaluation when differentiating between primary brain tumors and brain metastasis. Now, let's speak about predictive markers. Are there specific genetic or molecular markers that can help in predicting the likelihood of brain metastasis in patients with certain primary cancers?
So that is an emerging field currently, and I'll go into the specifics later on. But in terms of molecular biology of cancer itself, like we said, there are certain subsites of cancer that will give us a high index of suspicion that the patient is at an increased risk of developing breast cancer. So, for example, we know small cell lung cancer rapidly progresses to the brain. We know that leukemias and lymphomas, ALLs and UCLLs rapidly spread to the brain. So that in itself will give us a high index of suspicion. To those patients, we even do something called prophylactic cranial irradiation, which decreases the development of brain metastases in those patients. Then you get testicular cancer. Now we know with testicular cancer, there's a specific subsite called a choriocarcinoma. And we know choriocarcinoma has a high propensity to spread to the brain. So for those patients, as part of our workup, we automatically scan the brain. Then when it comes to specific genomics, and there's a big role now for something called next generation sequencing and understanding the biology of the disease and targeting specific mutations that occur in cancer itself. For lung cancer, there's something called a T790 mutation that has led us to believe that there is a specific drug that can target these patients because they have a high propensity for developing brain metastases, and now they've developed certain drugs that can target those patients specifically with the development of brain metastases. So yes, understanding the genomic landscape and doing these genomic testing can actually predict how what your percentage is of developing brain metastases and who is at a high risk and who is not at a high risk. So we can institute treatment rapidly, like we said, giving them certain drugs or doing prophylactic cranial irradiation for these patients.
Thank you, doctor, for providing valuable insights on predictive markers. This is certainly an area of great importance in improving patient outcomes. I hope it works out in the future. We will get a deeper understanding of it. Now, let's shift our focus to diagnostic tests and imaging techniques. In the evaluation of brain metastasis, which tests are commonly used? Also, are there any advancements in any new approaches?
So usually when the patient presents, we first automatically don't go and do a CT, right? We start off with and with anything in medicine, we start off with our clinical examination and our non-invasive tests. So like we said initially, if you've got a patient who's known with the diagnosis of cancer, do your markers, like your bloods, like your CA53, like your PSA. Those type of things can be done routinely, and your fundoscopy examination, do your CNS examination, so that we've also been taught in medical school that you can identify the lesion clinically before going into imaging. But the gold standard for actually detecting brain metastases is an MRI. That unfortunately is not freely available to all of us. So we often do a CT scan. And if we need to further evaluate the lesion, then we proceed to an MRI. MRI is not available in all centers. MRI is a bit of a specialized investigation, but you can get information from a CT scan itself, a CT brain. This needs to be done under contrast. So contrasted CT brain is important to be done. And like we said, we can identify the lesion, the amount of lesions that are present, if they need to be further defined with an MRI, and some more often than not, sometimes we have to do both. So we go on to an MRI. If, for example, the lesion is talking about specialized investigations, if the lesion is very small and we still have a high index of suspicion, there's something called a neuronav MRI. And a neuronav MRI is where they do an MRI, specifically a dedicated brain imaging. And, an MRI takes a long time to acquire, but these slices are as low as 1 millimeter slices, which means that you can detect a lesion that's even as low as 1 millimeter, which for us with new advanced techniques and stuff is very beneficial in terms of localizing the lesion and targeting it for our radiation. So yes, we've certainly come a long way in terms of how we investigate and work up these patients, and obviously understanding its limitations and availability, it certainly makes it much easier to detect these lesions and identify even a very early and small brain metastasis.
Thank you for explaining the diagnostic processes, Dr. Presha. Now, let's discuss the current treatment options available for patients with brain metastasis, and if there are any emerging therapies or clinical trials that show promise in improving outcomes.
So there's always clinical trials that are emerging. Oncology is a field where everybody wants to, even companies are invested in assessing newer treatments and newer therapies. So yes, there are a lot of emerging therapies that are going on, but a basic simple approach in how we manage brain metastases, starting off with, obviously, once we know that the patient has developed brain metastases, then we always discuss with a neurosurgeon. A lot of the lesions, like I said, even though they're stage 4, if it's a solitary lesion and if it's one lesion, they can be removed. There's no reason why they cannot, the neurosurgeon can go in and resect it. And now they've also got fancy ways and fancy techniques of doing an excision where it doesn't have to be an invasive craniotomy that they need to do. So yes, from a surgical point, we are developing. They now have expertise where they can remove lesions that are as much as 4. So it doesn't necessarily have to be one lesion. When it comes to treating with radiation, we have a fancy radiation which is called stereotactic radiotherapy or stereotactic radiosurgery, which can target lesions, like we said, up to 4 lesions, and preserves the actual functioning of the brain. So there's less toxicity to the actual treatment. So we've come a long way in terms of treating brain metastases with radiation. Then with actual drugs, there are a lot of drugs that can cross what we call the blood-brain barrier. These newer drugs that they're developing are designed specifically to cross the blood-brain barrier. So when it comes to breast cancer, we've got targeted therapies specifically for certain types of breast cancer that can pass the blood-brain barrier. When it comes to lung cancer, like we've identified certain mutations, these drugs specifically cross the blood-brain barrier. So treating brain cancer has changed completely compared to how we've treated them 10 years ago, which is beneficial for the patient itself, which is beneficial for us. And obviously from a prognostic point of view, there's ways now where we don't just say it's not treatable. Yes, there are studies that are underway, which now look at the combination treatment. So surgery followed by radiation, surgery followed by stereotactic radiation, surgery followed by the administration of drugs, combination of combining certain drugs to treat brain metastases. So yes, we're hoping for a lot of data when it comes to breast and lung, including prostate. Now with the newer therapies, they've also shown that there's promising data in treating brain metastases in these patients.
Also, assessing the need for surgical intervention can be a critical decision in managing brain metastasis. So how do you evaluate when surgical intervention is necessary?
Okay, so after we've done the scan, there are factors that will allude us to believe that this patient should be a surgical candidate. The first thing is there's patient factors and there's tumor factors. So patient factors, it needs to be a fit patient who needs to undergo surgery, and not only normal surgery, but neurosurgery. It needs to be a fit patient who's capable of doing that from a medical point of view. Then there's also, from a patient factor, control of the primary disease. There's no point taking out the deposit in the brain if the patient has extensive deposits in the lung. That's not going to change the outcome, because removing that cancer deposit in the brain, if you leave any active cancer behind, that will obviously then progress and spread to further deposits in the brain. So the primary needs to be controlled. The other factors that contribute to removing a cancer surgically from the brain is that it needs to be a lesion that needs to be in an accessible site for the neurosurgeon. It mustn't be in a critical structure in the brain, for example, the brainstem, the pituitary. If lesions, or in the optic chiasm, if those lesions are in those critical structures, then obviously the neurosurgeon cannot intervene. There also needs to be limited disease. It can't be, like we said, more than 4, or extensive swelling of the brain, or for us to treat with cure. Be that as it may, there's still a role for neurosurgical intervention, even in those patients that are complicated. And as much as they cannot surgically remove, they can still intervene with shunting for a patient who has developed hydrocephalus. So those are still surgical candidates if they fit. So all patients that we actually have with the development of brain metastases, the gold standard is to ideally discuss with the neurosurgeon. And if they cannot surgically intervene, then they do the shunting procedures, because there's still a quality of life benefit for those patients.
Thank you for sharing that perspective, Dr. Presha. Lastly, are there any preventive measures or strategies that can be taken to reduce the risk of brain metastasis in patients with primary cancers?
Yes, there are multiple strategies. So if you've got a cancer diagnosis already, like we said, within the cancer diagnosis, we've identified patients who are at a high risk of developing brain metastasis. So we scan the brain, and if the brain is negative for certain cancers, we give them what we call prophylactic cranial irradiation. So that's one of the ways where we can prevent brain metastases for your ALLs, for your CLLs, for your small cell lung cancers. We automatically, if the brain is clear, we'd give them the prophylactic cranial irradiation. When it comes to cancers that are not, that prophylactic cranial irradiation hasn't been looked at, in data is low in terms of its response, there's still things that can be done. And the main thing is compliance. Like we said, if you've got a very treatable breast cancer, complete your treatment. There are things like taking your tamoxifen for 5 years. If you're non-compliant with that treatment, those endocrine therapies, yes, you can. There's a high chance of your cancer progressing. So to prevent that from happening, be compliant with your treatment. Maintain regular follow-ups. If you have any development or progression, let us identify it early so we can change your treatment early on, as opposed to just leaving it be. One of the main challenges that we have is delayed health-seeking behavior. So it's not only from before the patient actually presents to us, it's while they're on treatment. Automatically, patients say, I will wait for my appointment. And most often than not, this is a problem. If you can see that there's something that's progressing, and clinically, we rely on the patient to think that, or know their body themselves. So they're the first person to say, no, something is not right. Don't wait for your appointment. Go to your healthcare professional, even if it's a primary healthcare professional. They're welcome to call the oncologist or call the oncologist itself, and we can obviously intervene at that point. These type of interventions have been shown to delay progression to prevent the development of brain metastases, to prevent the development of the morbidity that's associated with it.
Thank you, Dr. Presha, for sharing your valuable insights on brain metastases in oncology. Definitely, prevention is better than cure. Thank you for sharing your expertise on this topic. Your expertise and research contributions are truly commendable. It was a great pleasure to have you here today with us. Your contribution has given us a better understanding on this topic, and we're very grateful for your presence here today with us.
Thank you, Dr. Nijar. Thank you for having me. It was actually a pleasure, and I commend you for the initiative that you've instituted in this regard, because I personally believe that early identification is paramount in assessing, when to intervene, and knowledge is power. So thank you very much for this initiative.
Thank you. Thank you so much, Doctor. And thank you to our audience. Thank you for tuning in today's show. We hope that you found this discussion informative and insightful. That's all the time we have for today. We'll be back soon with more compelling topics and expert guests. Until then, stay well and goodbye.